My name, Hello, my name's Kelsey Ufholz, and I'm a research scientist at the Case Western Reserve University Department of Family Medicine and Community Health. And this morning I will be interviewing Dr. Goutham for you. For those of you who have already been on the call, Dr. Rao is one of the co-PIs of the UH Advanced Center, but even more for our interview today, he and his team were the ones who developed the concept of a diagnostic path through an AHRQ-funded study back in 2013. And he's here today to tell us a little bit more about that. Good morning, Dr. Rao.
Thanks, Kelsey. Thanks for leading the session this morning.
Of course. So you've written quite a bit about how there is not enough evidence-based guidance for diagnosis. Can you talk a bit more about that?
Yeah, first of all, there's a number of prominent examples. So if you look at treatment guidelines, treatment of sepsis, for example, treatment of blood pressure, treatment of diabetes, you'll find that most of the underlying evidence is based on randomized control trials, comparative effectiveness studies, et cetera. We don't find that in terms of identifying the best diagnostic approach to a problem. And there's a couple of examples I'd like to highlight. For example, fever without source in infants, which is a serious problem. Until a few years ago, the guideline was basically an opinion statement from the 1990s, even though the pathology of underlying fever in infants has changed a lot, and immunizations have changed a lot. We relied upon that. And that's typical of a lot of guidelines. So, for example, for migraine headaches, the diagnostic portion of the guideline is based on consensus and opinion, but the treatment, this is in adults, as far as what treatment works best, is based on randomized control trials. So we're really at a point where there's a serious lack of how best to approach diagnosis. Part of it, I think, is that as physicians and other healthcare professionals, we see diagnosis as sort of an art form, something that can't be studied, something for which systematic approaches are not always suitable. And I think that that's a false notion for the most part.
So why do you think it is that we have this problem of not enough guidance for diagnosis?
Yeah, it's a good question. So I think part of the reason is the way that we see diagnosis. I mean, when I went to medical school, more than 25 years ago, it was, you do your history, your physical, and then there is this thought process that's a little bit nebulous as to what a patient might have. And that was all seen as outside of the domain of randomized trials and evidence. So when we got to, okay, well, now this patient has sarcoidosis, we know that a course of steroids might be suitable in this case, et cetera, et cetera, et cetera. But to get to that point, that was something that was seen as very individualistic. The patients were so variable that there was no way to really study it. And so if you don't have a lot of evidence underlying things, you're not going to approach it systematically. The other thing is diagnosis is very difficult to study. There's no question. And so what winds up happening is we look at the value of specific tests. For example, what's the sensitivity, specificity? What are the test characteristics of one specific test in one group of patients? Which is not always the best way to do it, because we don't look at specific tests when we practice medicine. We look at patients as a whole, their entire picture, the entire approach to get to a diagnosis. And that's very difficult to study. I'd say another reason is that until recently, and this has changed, and obviously the UH Advanced Center is an example of that, there hasn't been a lot of research funding from NIH or from AHRQ or from PCORI that focuses upon diagnosis itself. Now, the 2015 National Academy of Medicine's report on diagnostic error, I think, was an impetus to stimulate more funding in this area. So there's multiple reasons why we lack guidance.
Okay. And I imagine that there are certain conditions or medical problems that are more in need of guidance than others.
Yeah, a lot of people would say that there are dozens of them, but I think we can establish, many years ago, we established some basic criteria for things that ought to be studied in terms of their diagnostic approach. First of all, the problem that you are studying should be associated with both very serious and benign conditions. So if it's always benign, it never rises to the level of a priority for research funders, et cetera. Let me give you an example. Sore throat in adults, it can be associated in some cases with serious conditions, or maybe there's a malignancy there, epiglottitis, although highly unlikely. But for the most part, at least in primary care or in the emergency room setting or urgent care setting, it's a pretty benign condition. So whether or not they have a viral sore throat or a bacterial sore throat, you can say, yes, it influences treatment, but it's not a life-threatening condition. And that would not be a high priority for us, right? Whereas a condition like abdominal pain can be reflux disease, which is relatively benign. It can be functional dyspepsia, or it could be gastric cancer. It could be, it could be a peptic ulcer. It could be something very, very serious as well. So that's one of the criteria. It should be associated when we prioritize diagnostic evaluation, both serious and benign conditions. It should be relatively common as well. If it's very, very rare, sort of allocating resources to studying it as a problem is not the best use of limited resources in that condition. It should be associated with significant variation in how physicians approach the problem. If everybody has the same systematic approach to it, let's say it's chest pain, for example, which is still, there's many different causes of chest pain. But if the approach is relatively uniform, chest pain in the ER, they all get their cardiac enzymes, et cetera. If it's relatively uniform, it's not necessarily a high priority for diagnostic evaluation. The final criterion is fairly simple. The guidelines and other guidance that are available should be of limited quality or limited availability. For some of these conditions, there's absolutely nothing available. So that makes it a priority for diagnostic evaluation and studying diagnostic practices for sure.
Got it. So returning to the concept of the diagnostic pathway, can you describe that a bit more for those who don't know what it is? Yeah,
so a diagnostic path is quite simply all the steps that are taken from first presentation of a patient with a particular condition. Let's say it's abdominal pain, to the point at which there is a diagnosis that is established, which becomes the basis for treatment. So when we say first presentation, somebody presents, let's say it's a healthy 40-year-old man who presents with abdominal pain. You're going to do a history. Those are legitimate steps in the diagnostic process, a physical examination. You will order tests. You may make referrals. You may do procedures. You may arrange follow-up at a specific interval. You may prescribe medications empirically to see if there's a response. All of those fall along the diagnostic path until you say, yes, this patient has peptic ulcer disease, or yes, they have gastroesophageal reflux disease, or whatever it happens to be. So all of those steps are important. So it's almost like a story or almost a map. So the first presentation, first visit, when do we get to a diagnosis? What are the outcomes, I think, of a diagnostic path? The outcomes are very important. First of all, the accuracy of the diagnosis, which often will evolve over time. The timeliness of diagnosis. Anybody can make a diagnosis if the patient keeps getting sicker and sicker. This often happens when primary care physicians refer patients to specialists, and they're saying, well, how come the primary care physician didn't know what this was? Because during that interval, the patient has developed symptoms and signs that make it more obvious. And the third one's very important. It's how many resources are used. I mean, everybody gets a whole body MRI when they come in with abdominal pain to any sort of setting. You're probably going to establish a diagnosis, but that's not exactly valuable. So those three parameters are what we are looking for in terms of a diagnostic path and what it looks like.
Okay. You said earlier that there are some conditions that might be better suited to this approach than others. Could you say a bit more about that?
Yeah, so some of the conditions are, when you look at a medical textbook and you're reading, for example, it's organized by diseases for the most part, even now, even if you look at something such as UpToDate, which is a very popular resource that's used by students and residents and physicians all over. For the most part, what will happen is you will have a suspicion of a particular underlying condition. Let's say it's temporal arteritis, which can be fairly serious. And you'll go to UpToDate and you'll read about temporal arteritis and you'll read about its symptoms and signs. And then you'll think about your patient and say, well, gosh, I think this patient has temporal arteritis or doesn't have temporal arteritis. It's almost like it's a bimodal outcome, or two possibilities for the outcome. But when we think about diagnosis, that's not really how we go about things. Patients don't present with, gee, doc, I think I have temporal arteritis. Can you tell me if I do or not? They present with symptoms, and they are often undifferentiated, meaning they have not evolved into finite disease entities yet, at least according to the physician and the patient. So they don't present they will present with headache, they'll present with jaw pain, they'll present with chest pain, they present with abdominal pain, they present with dizziness, which is one of the most vexing problems. So it's that large group of undifferentiated conditions. In other words, things that haven't evolved into finite illnesses or are associated with so many underlying conditions, it makes it challenging. If you think about it from the emergency medicine standpoint, abdominal pain is probably the most challenging condition. Chest pain, dizziness is extremely challenging. So those are some of the high priority conditions that we think about in terms of the usefulness of diagnostic paths. And what we can actually do is look at not one or two patients to see what the path was, but to look at thousands of patients to identify patterns that are associated with three very, very important outcomes, which we can talk about in a moment. But the highest priority problems are undifferentiated. In other words, nondescript symptoms. Fatigue is another classic example as well.
Mm-hmm. So the goal of this is to develop evidence-based guidance for diagnosis, which means there needs to be a measurement element. Can you talk about how you might measure the value of this approach to diagnosis?
Yeah, so it's very challenging, first of all. So we talked about some key outcomes. One is timeliness of diagnosis. Anybody can probably get to, let's say somebody comes into our family medicine primary care clinic and they have abdominal pain. If you can say, well, let's just wait and see what happens. And of course, it might wind up being very serious, or it might be completely benign, it might disappear, etc. So the timeliness of diagnosis is important. Of course, the accuracy is important, and that often evolves after the fact. So I may have established a diagnosis of peptic ulcer disease, but it might wind up being pancreatic cancer or something more serious later on. So accuracy is important. And we talked about resource use as well, not throwing every single test at the problem. Now, your broader question is, how do we measure all of these things? Well, in terms of timeliness, it's fairly straightforward. It's the first presentation of the complaint to the time at which a diagnosis is established upon which treatment is based. It doesn't necessarily have to be accurate, because that's a separate outcome measure either. So if somebody comes in the first visit, I say, yes, this is obviously peptic ulcer disease. We're going to treat you accordingly. I'm done. Okay, one visit, 30 minutes after presentation, the diagnosis is established. Obviously, that's a very timely diagnosis. Accuracy, again, is something that we would measure over the long term. So the real diagnosis sometimes will evolve over a course of a significant amount of time. And resource use, you can look at simple laboratory tests that we order. And when we study diagnostic paths, we don't say, well, a CBC versus a BMP versus something else, because they're all relatively simple. You start to accumulate significant resources when you start to make referrals and imaging tests and procedures. if everybody gets an upper endoscopy the moment they present with any sort of abdominal pain, that's not necessarily the best use of resources. So we measure all of those and we try to balance those in terms of what is the most valuable, where is the highest bang for the buck. And it turns out in many cases, a thorough clinical evaluation, a history and physical will often lead to the most appropriate diagnosis early on. So those are the most valuable or cost-effective measures that you have in the diagnostic process.
Mm-hmm. Yes, and it sounds like there's a lot of considerations to be taken into account with this.
Yeah, it's very difficult. We talked a little bit early on about how difficult it is to study diagnosis for a number of reasons. Some people don't think it should be a priority to study diagnostic approaches, that everything is too subtle or too nuanced, or my patients are a little bit different, et cetera. And we know from the literature that that's not necessarily true. But that's a limitation, is adopting an approach to diagnosis that is more systematic. The other, I think, thing is that how do we actually study it? It's hard to study in real time. People don't like to have their diagnostic processes evaluated in real time. So we use electronic health records, and those are prone to a number of limitations. So you can look at a few health records, and let's say I'm looking at how is headache managed in our family medicine clinic when a patient presents with first headache. And for the most part, of course, it depends upon the signs and symptoms. And we want to know what questions are asked of the patient. We want to know, is imaging ordered? Are medications tried empirically, for example? Are referrals made if it's an intractable headache, et cetera? And we can look at that and we can try to identify patterns. One of the problems is there's no way to identify a pattern if it's one or two patients. You have to look at thousands of patients. And to say, so that you can come to a conclusion such as, in patients who present with first episode of headache in primary care, initial imaging, this is a more obvious one, is probably not useful. There's not a whole lot of yield. It doesn't change your management. It doesn't help you establish a diagnosis, but you would need to have very, very large numbers. The biggest limitation, Kelsey, is that what's written in the electronic health record doesn't necessarily reflect the thinking of the physician that's involved. So somebody comes in with abdominal pain, somebody orders a CBC, a complete blood count. Was that really for the abdominal pain, or was it for something else, or what are they thinking? And how does the result influence further diagnostic evaluation? Let's say it's abnormal and additional tests are ordered. It's very difficult to study it in that fashion. So you need very large numbers. You have to select your problems very carefully, and you have to be careful about how you assess our outcomes. And you and I are working on unintentional weight loss, and our most serious outcome in that case is malignancy. So we can look at unintentional weight loss, see what's ordered, what's valuable or not, how long it takes to get to a diagnosis, and whether or not that diagnosis is accurate. So the electronic health record and the data associated with it provide an opportunity, but it's an opportunity fraught with difficulties as well that we are, you and I are trying to overcome as we move forward in this area.
Yes, like many research problems, you're limited by data quantity and data quality.
Absolutely, definitely.
Mm-hmm. So, do we have any questions from our viewers for Dr. Rao? Anything in the chat?
Yet, we'll scroll through. There's a few people that are unmuted, but
No.
Okay. Well, I think the final point is, I think that there are many ways to study diagnostic approaches, and this is one particular way to do it. There's more direct observation of patients in specific settings. The other thing you'll find is that for the most part, research in diagnosis focuses on the value of one particular test or one particular question or strategy. I was involved in something called the Rational Clinical Exam Project. Some of you may have seen the papers in JAMA, and I was the lead author on a patient called, does this patient have Parkinson's disease? But the challenge with that is it extracts the value of different tests and maneuvers from individual studies and pulls them together into an approach. And that's not how we see patients. We see patients with a tremor. We see patients with chest pain, et cetera. We have a question from Dr. Conroy. Please comment on aspects of how to leverage implementation sciences to address and study. Yeah, great question. So let's say that we have a very, in the UH Advanced Center, we have a very well-defined approach. What we are doing essentially is identifying problems that we think are especially prone to diagnostic error, that are common, that are associated with benign and serious conditions. We are looking at how those problems are approached now, and we are trying to identify best outcomes associated with different approaches. Then we will present them to a diagnostician's panel, and the panel will weigh in on those, and then we will and then we will come out with hopefully at least more than one paper, hopefully. And this is kind of the systematic approach that we are taking. So that doesn't really help you when you think about how we try to influence physician practice or provider practice. When I'm old enough to remember when they used to mail guidelines to people, and people would throw them in the garbage or not read them and not absorb them. That doesn't work. You have to implement best diagnostic practices in a systematic way. And there are innovative ways of doing that, including using the electronic health record. We know that one of the most influential things that one can do is to inform a physician about what his or her peers are doing under similar circumstances. So for example, a patient comes in to the emergency room because that's a place where diagnosis is especially challenging in some cases, and they present with abdominal pain, and I'm about to order an amylase test on this patient. And of course, something pops up and says, in patients like this, 4% of your colleagues are ordering an amylase test. And I'm saying, oh, wow, maybe I ought to rethink that. Let me go back and think about it in a way. So that's a form of implementation, I think, that is especially potent, looking at what peers are doing and not just presenting the guideline to people, because that may not have an influence, or doing seminars and that sort of thing, but real-time information about what is actually going on. And Dr. Conroy asked about AI as well. And I think that's the role that AI will probably play in diagnosis, is looking at your patient, looking at some of their key features, and then making recommendations, not hard and fast, but not based on computer data, et cetera, but to say, hey, most people are not doing this right. They're not getting imaging in patients like this. You can go ahead and do it, but we just want to let you know that. Dr. Solomonides, are there common cases where one condition hides another? Absolutely. And dizziness, he mentioned stroke. Dizziness is a really, really common one. So stroke is especially prone to misdiagnosis, especially in acute settings. It can be benign positional vertigo. One of my colleagues, our mutual colleagues, Dr. David Newman-Toker, is an expert in this area. It can be disguising a stroke in that case, a mental health condition, right? Somebody who's just dizzy or whatever it happens to be. That may be a side effect of medications as well. But often conditions are misdiagnosed. In other words, accuracy becomes an issue because there's something that's masquerading as under the same condition. And then Britt is just thanking me for our insight. Well, thanks very much, Britt. Any additional questions or comments? No, it looks like we're good.
Mm-hmm.
Okay, well, thank you, everyone. If you want to learn more about diagnostic paths and the approach we're taking in the UH Advanced Center in general, I'm happy to send out an earlier paper from about 5 or 6 years ago that will describe the approach in more detail.
Okay. Okay, I think that brings us to our discussion for today, and thank you to everyone who logged in, and we'll see you at our next one.
Thanks, everyone. Take care. Have a great day.
Thank you.